So people who've just joined us online, this is what we're going to be covering. Hopefully you're in the right place, because it's a bit late now. If you're not, you have to stay and listen to the health-based youth work talk. So I got halfway down. So as a group, we've been collecting some data on different youth workers who are working in health-based settings, because there's a whole massive collective of these people, which is amazing. So we're going to talk about the who, where and why and how, and then I'm going to pass over to Sarah, who is going to add a little bit about health-based youth work in context. So she's going to talk a little bit about her role and the practice side to bring it to life. And then we're just going to kind of end with health-based youth work, where next. And we've got this little random film to show you at the end, and a little exercise for you to do. This is our creative youth work skills coming out. It's a bit abstract, and it'd be interested to see how it's received. But yeah, there's a little 2-minute film and then a little thing we're going to ask you. So that's what we're doing.
So this is where I come in. There's a really big picture right next to you like that. This is terrible. So yeah, a little bit about me, and then there's some stuff on the screen, obviously. But I'm a mummy, first and foremost. I have been a youth worker since 2005, and I kind of got into youth work because as a young person, I had faced challenges, had difficulties, and actually with other people who gave me a bit of space to talk about what was going on and help me find my way, kind of navigating that really enabled me to get where I am today. And I think that domino effect occurred, and I ended up wanting to kind of give that back, which is what led me into youth work. And now my focus is very much on long-term health conditions, supporting young people to adopt positive health behaviours, but through their own choice and understanding their own choices. Random facts: I used to be a professional dancer. That was a long time before. And I love a bit of walking. In fact, who was it mentioned Wales? I walked up Snowdonia 2 weeks ago, and I dragged my 8-year-old with me.
I left her there.
Yeah, she didn't have a choice. Obviously, I followed my youth work principles. She didn't have a choice. She came up.
Fab. Next one, please. So a little bit about me. I'm a twin. I'm neurodivergent. I've got ADHD. You can probably guess that at the speed that I talk. I've got a JNC in youth work and a master's, and I'm a qualified assessor. I worked as a youth worker more in an education context, and then targeted youth support, and then in the last 6 years before where I work now, I was working in the NHS, but in service development. So I set up an eating disorder service, a number of mental health support teams and crisis teams. So I kind of submerged myself in the world of the NHS. And I've now got myself and a couple of others have got a not-for-profit organisation which is based in the Thames Valley, which is running youth projects and also doing some consultancy support. And one of the things that we help with is the network, to coordinating the network. My interests in mental health, youth voice and neurodiversity, no surprises then. I'm obsessed with the river. You might think the River Thames. I don't live in the north, even though I've got a northern accent. I live in Bucks, sort of near High Wycombe area, and love anything to do with the river. It's like just this amazing sense of calmness, which at times I need. I've just started the Couch to 5K. I was going to put I was a runner, but I can't put that on. So I'm trying to be a runner. And then I can't beat the dancing one like Sarah, but I'm fast-paced, creative, so ideas, and good at joining up the dots. So one of the things that I did when I was in the NHS is join up the dots with the youth work world. So it's just a little bit about me. So over to Sarah.
So this is a little bit about the health-based youth workers group. So Jeanette kind of touched on it. It's grown immensely. So I've been a health-based youth worker for 4 years, and I think, if I remember rightly, when I joined the health-based youth workers group, it was kind of 50 youth workers on that group, and I think now I'm letting a cat out the bag.
You're allowed to spoiler.
But there's way over 100 health-based youth workers within that network, and that's just the youth workers that are in that network. I'm sure that there's more health-based youth workers. I think that the important thing about the Health-Based Youth Workers Network is, as youth workers within a healthcare setting, we're surrounded by lots of professionals that we can get a bit lost in, we get a bit lost. So it's really nice to have that network of youth workers going through that same journey, navigating that same system that the NHS essentially is. So if it's confusing for us as youth workers on the inside, it's got to be super confusing for the young person on the outside. And that's kind of, having this group helps us navigate that, I think, is really important. Just a couple of dates, really. It was first set up in 2009. Donna Hilton, who sadly couldn't be here with us today, is the chair of the Health-Based Youth Workers Group, and she set that up in 2009. And as Jeanette mentioned, last year we had a little bit of a refresh, and Brighter Futures Together has given us some extra support, which has allowed us to kind of remarket ourselves, re-campaign ourselves, and kind of go out there and get a lot more youth workers, which is really good. It just feels like there's a lot of energy now behind the group, which is great. We have coffee and chats online. Bring your own coffee, bring your own chat, which is always really good. We have regular news bulletins. Jeanette and the team and the steering group that are behind the Health-Based Youth Workers Group that we're introducing in a moment, we're really good at sharing bits. So we're on the NHS platforms, which is obviously a really good space to ask questions. But if something really pertinent comes up, we can share that immediately on that platform. And we also have an annual conference, which has been running, I think, since the year that it launched. But we're really excited to have our first face-to-face annual conference again this year in October, because there's been a bit of a gap. There's been a gap in those for a few years due to COVID.
Go on.
So this is our steering group. I mentioned Donna Hilton shipping, Jeanette. We do this.
Now you go.
So I mentioned Donna Hilton, who set up the Health-Based Youth Workers Group. She is our chair. And then there's Sandra, who is also known as the tech gremlin. Tech gremlin. Should have brought him with us. He's great. There's myself, Emma.
My line manager.
Yeah, I'm going to say, you might know over there, who works at the Royal College of Paediatric and Child Health. We've got some youth workers as well, some more youth workers, Charlie, and Charlie's in Wrexham. Louise, who works for NHS England now, but was previously a youth worker in a hospital setting when she first joined the steering group. Nicola, who's in Manchester, and Sean, who's in Wales. So even just through that steering group, you can see that geographically, we're really spread out, and we kind of, having that spread geographically really helps us kind of bring together our regions and make sure that we're all reaching out into our regions to help that growth of the network, making sure that people around us know that it's going on.
So just a little bit about young people's health. I'm not going to read all the statistics. Most of these are about sort of long-term health conditions. I think about a quarter of young people will have a long-term health condition. So although adolescence is a time that most typically people are quite healthy, it's also a period where good outcomes rely on young people's health services that are friendly. So if we're going to achieve good outcomes, we need our health services to be young people friendly. And I think that's one of the things about youth workers in that context, making them much more sort of holistic and young people friendly. So I'm not going to read over all of those, but the context is a number of long-term conditions there. And then the one just in the blue, which is perhaps the biggest thing at the moment, is the mental health, which I could have filled this slide with just mental health stats. So most young people through adolescence are healthy, but actually we look today and that apparently a quarter of young people will have a long-term health condition. So there's a big cohort of young people that kind of need that extra input. The source of this, if you've not seen it, is the Association for Young People's Health. We've got amazing health data on there. There's a whole portal about health data on that. It's amazing. Next slide. Now, what health services do people interface with? We could have written a whole presentation on this because, like I say, the health landscape is really, really complicated. And I think people sometimes just think, oh, well, the NHS is just one big organisation. But young people might interface with any of these places. And interestingly, on the Association of Young People's Health, it talks about how year 10s are seeing the GP a lot more. And we've got this myth that young people are not going to their GP. So it's interesting. So these are the different bits of health that they might interface with. What we know typically are general practice, A&E, but then we've got things like the child health services. So in schools, we've got school nursing services, and then we've got more back to secondary care, all the mental health services, and then the one on the right hand side. So in terms of actually healthcare providers, these are all the different types of bits of the NHS. And this is where, if we drew a web, it would be a complex web of loads of different organisations. So when we start looking at where the health-based youth workers are and what they're doing, they might have a similar job title, but their roles are very different and they're all in different organisations. And that's illustrative of what is behind that health planner. And thankfully, not everybody sees that, and thankfully young people don't see that. But we've got different primary care organisations, we've got the acute trusts, we've got mental health, and then now this emerging charities, social enterprise, and the third sector, who are rapidly coming in and helping the NHS. And if we look at the health-based youth workers, a number of them are actually in those organisations. So that's just about the health service at a glance. So in terms of the health-based youth work, I was trying to do a really detailed chronology, but I then summarised it in 4 stages. So if we look at where health-based youth work has come from and where it's going and maybe the future. So in terms of health-based youth workers, what we're doing is defining it as not just youth workers in hospitals. So that's where it kind of originated from. But the steering group kind of we looked at this concept of trying to define health-based youth work, which was actually quite a challenge, and we defined it as youth work in hospitals and or other healthcare or health-based settings, which makes it a lot broader. And I think if we look at when it started back in 2000 in Nottingham, Sarah mentioned Donna, who sadly is with us today, but she set up the first hospital youth service, which has gone on and won lots of awards and is a bit of a flagship in terms of positive practice. That's still going. So although this, what Sarah and I were saying, we didn't want people thinking it was a linear process. So the driver was transitions, and then it changed to something else, and then it changed to something else. What's happened is the drivers for health-based youth work, these are like adding on. So then after that, we had Red Fred and the violence intervention programme. So you've probably heard across London, linked to the whole knife crime agenda. So a different agenda driving it. So the first agenda was that concern about transitions. Then there was a big concern about sort of our trauma centres and A&Es. And again, Red Fred 2005, still operating in London, Nottingham and Birmingham, and do lots more of health-based youth work. It's not just ones in hospital emergency departments. Fast forward to more recently, and we've got that whole social prescribing agenda, and it is the overlap with youth work. Interestingly, when we ask people what they do, social prescribing is kind of a big element. In 2022, there was a rapid evidence review of social prescribing, and there's a lot more review clinical research about social prescribing happening at the moment through UCL. Alongside that, we had the NHS long-term plan and the mental health support teams. So I'm sure you know about mental health support teams. They're new services across the country. And their early intervention services in mental health based in schools. And this was a massive injection of cash into the NHS. And what mental health teams have done is force the NHS to think about skills mix in their team. So thinking about actually, if we're going to work in education in a clinical sense, in a clinical sort of role, would it be helpful if we had a youth worker with us? So, or would it be helpful if we had an assistant psychologist with us? So those teams have led people to start thinking about skills mix. Plus, there's a massive shortage of clinically trained clinicians, so they needed to think outside the box. There's going to be 500 mental health support teams by 2024. Massive, massive agenda. Fast forward to now, integrated care. That's what's driving the agenda now, this need to think in a more integrated way and not to be siloed. And 2023, NHS England, this is just England, and we are got people trying to say what's happening in our other bits of the country, but they announced a number of hospital-based youth work pilots, 7 sites across the UK, 20 to 25 youth work posts in each, about 200 grand for each site, a massive amount of money. So actually, we know that the NHS has got challenges and struggling, but who is actually investing a lot of money in youth work at the minute? It's actually the NHS. So just an interesting reflection. So that's kind of the journey to where we are now. So I think what we wanted to say is this amazing thing about youth work, how it can weather a storm. So not only do youth workers help young people navigate their own storms, but actually as a professional, it can weather the storm. It can survive these challenges out there. It can survive the cuts. It hangs on by a thread and then it comes back reinvented. And we just like that concept, didn't we? Weathering the storm. Next slide. So back to what we're actually here to talk about. Important we set the context. So in terms of the data collection, this was not a piece of academic research. It's literally something we've done as a group, sort of informally, but it's given us some really good insights into what's happening across the country with health-based youth work. I think Sarah let the cat out of the bag, which 124 individuals in the network. So these are people who are self-identifying as health-based youth workers. We asked them a series of questions when we relaunched the network. There was up to 20 questions. Where do they work? What do they do? How would they define themselves? What's their qualification? And what we've got to do is show you some of those insights. The questions were co-designed by the health-based youth workers group, but I just must stress the limitations of the data. It's not a piece of academic research that's gone through a whole rigorous process that research does. And so we're going to profile the who, how and what of the roles, as opposed to the impact, because we would have needed another 50 questions to look at impact. So the first thing was, what are the job titles of people? I know that sounds like a stupid question, but actually when we look at it, there are lots of different titles, hence the problem. So when we think about social workers, they're all called social workers, doesn't matter where they work. A nurse is always called a nurse, doesn't matter where they work. Whereas actually we've got a whole raft of different names of people. So we just did this word cloud. Interestingly, about 48% actually answered youth worker to that question, which we were quite pleased about. It'd be much easier if we put what it does in the tin, on the tin. So yeah, that's just some different names. And I think some of them are context. So the renal health youth worker, the congenital heart disease are good because it tells you what environment they're working in. Next one.
Can I just ask a question about that slide? You mind?
Yeah.
So are these people who are trained as youth workers who then become hemoglobinopathy youth workers, or are they clinicians who
They're
adopt
not clinicians. Well, they might be randomly.
I was literally about to, I was about to pick that one out because, and it, like you say, it gives you an example of a context of where they're working, but it could be misleading.
Very cool. So a JNC youth worker would become a renal youth worker and then learn loads of things about kidneys and dialysis. And
Yeah. So I started as a renal youth worker, so I'll give a little bit of context to that.
Yeah.
But as a youth worker, my theory, and when I talk to my team about it, it's kind of like, actually, if you imagine a young person doesn't understand all that medical jargon, so it doesn't matter that we don't understand that medical jargon because we're helping that young person navigate it. So we're doing that journey with them rather than being informed.
Yeah.
wow.
And I think what's been interesting, certainly, I mean, I was working in the NHS in a different role, but it was doing service development, and we set up a few youth work things. I was thought that I would have imposter syndrome with all them clinicians. They never. They were the most amazing people I ever worked with, and they absolutely loved the difference. They actually didn't want lots of people like them who think in a clinical way, and it's all about talking therapies, because they realise that actually the challenges that young people are facing are not always met by a certain approach. So I think that different way of thinking is often welcome. Yeah. Next slide, please. So, interestingly, most people are actually based in NHS organisations. I was actually quite surprised by this. I thought we'd have more based in charities. So 84 of the people, a couple in the community interest, but most in the NHS. And then the people in the charities, lots of them have got honorary contracts with the NHS. So they sit in a charity, but they've got another contract with the NHS to use all the NHS things. So yeah, again, the NHS kind of dominating this space. Interestingly, 88% of the total cohort were on permanent contracts. We were really surprised by that. I thought there'd be loads on fixed term contracts and maybe sessional, but no, most of them are on permanent contracts.
Can I just ask a quick question on the charity sector?
Yeah.
Have you mapped out the size of that charity? Are they national big charities?
Good.
Are they
Good
third
question.
sector small organisations?
So there was a mix, and there was a question that we asked: are you regional? Are you national? Are you regional? Are you local? But I looked at the data set, and it wasn't reliable enough, because there were some people that had put national, and I know the organisation, and it's not national. This is why we need more research, like research that goes through more rigorous process. But I think, interestingly, what I was trying to do was to look at that. How many of them in these national charities, like Diabetes UK, and there are, I'd say I must have found at least 10 or so, don't quote that were national charities.
But the TYA have a big, they have a number of youth workers that they put into different hospital trusts under the TYA.
Oh,
so
yes, yeah.
A lot of the teenage cancer.
Yeah. So I think those big long-term health conditions where you've got an overarching charity that like Diabetes UK or whatever seem to again are already around the table, which is positive.
I think it would be potentially national as well. If it's UK wide, it would be national to Wales or Scotland or Northern Ireland or England. So I think it'd be hard to tell without saying what way from.
It was that's the thing. You ask a question, and then when people answered it, I was like, oh, we should have asked it this way. But then we asked also what age do people work with, and that data wasn't reliable enough. So that's why I've not put it up. But that I think most of them were 11 to 25. So this myth again, that we know that transition is a concern. But it wasn't reliable enough. Next slide. How is your post funded? So again, obvious, most of them are the NHS, but some did say through charity sector, corporate donations, and a lot didn't know, this is people on the ground, so maybe we wouldn't expect them to know. Interestingly, where I work in Berkshire, we've set up some health-based youth workers in CAMS, and it's actually funded through UK Youth. It's not funded through the NHS or through health. If it needs to survive and carry on, it might need to have the NHS funding it. So that's a challenge we face when you get these other big pots of money. Next slide, please. So we asked if there were other youth workers in the team. So is it somebody on their own? Because that sort of presents a bit of a challenge for so many reasons. And actually, most people said that they were in a team with other youth workers, which again is good. And I think what happens is you maybe get one, maybe like where Donna started, and then the team grows and grows and grows. So yeah, but most did say fewer than 5. So we've not got these massive teams, but
a lot of it starts is once the trust of the hospital setting that you're in recognises the benefit,
the value,
that value, and then they invest in that value, and that's where I think
that's when you get a ripple effect. Yeah. Then we asked about which health-based health setting do you work in. So I'm not going to talk over these. Most people say that they work in multiple settings. So there's not just lots of people sort of in A&E, they're working in different settings, which again is about the principles of youth work, going to where the young person is, quite literally. And 86 out of the number said this multiple settings. Next slide. And then we asked which long-term conditions do you focus on? Most people said either all long-term conditions or none of those, but we didn't then ask them what they mean when they say none. I think a lot of them meant mental health when you see the next slide. So the next slide is which other areas. So 67 in mental health. And I think we're just going to see that go up and up and up. But also with these new youth work pilots, again, that landscape might change. So we asked about qualifications, and we asked how many of you have got a JNC qualification. 83 said yes. I was actually quite surprised at. And majority are at degree level. We also then said, if you haven't got a JNC, how would you define yourself? And the people who answered said that they've got extensive work experience with young people. So they were talking 5 years plus of working with young people. And a number of them had psychology, social work qualifications, or different sort of that wider allied professionals. And what's interesting is when I was working in CAMS, the allied professionals, they define as occupational therapy, social work, physiotherapy. So they're the kind of jobs that you can jump from that into being a mental health practitioner. Whereas maybe when we talk about allied professionals, it's should the youth work role be in there? Because really it is. And then the most important answer, we asked what do you do in your job? The question often people get asked with youth work. And most people said that 11 different answers on this. So they're doing a whole range of different things. And again, the navigating, signposting, the emotional health support, group sessions, one-to-one support. There's nothing kind of on there that kind of surprises us. It just gave us the data to say, actually, this is really multifaceted. And it depends on where the young person is at, and it's about sort of meeting their needs. And social prescribing, I thought social prescribing might have been a bit higher actually than that, out of the ones. So I thought that's a biggie. Maybe we just call it navigating and signposting.
I think yeah, it comes down to what that means, isn't it?
It does.
I think a lot of us do social prescribing because there are social prescribers.
Yes,
out there.
yeah. You don't want to say, oh, I'm this, because now I'm just going to hand over to Sarah, who's just going to talk. That's the data. It comes with some caveats. It wasn't a proper piece of research. What I would say is that we do need more research on this area. And I'll talk a little bit about that at the end. I'll just say a little bit. Sarah's going to just talk about context.
So this slide kind of explains to us just some of the issues, because we couldn't get all of the issues that young people face, and we know as youth workers that this is very individual. So what one young person finds, an issue and a difficulty, another young person may not. But these are some of the common things that young people are facing in today's.
I talk about young people with health conditions.
No, I'm not. I'm talking about generally young people.
You've caught a thread.
Yeah. So we know, and we, looking at some of the data here that Jeanette has kindly done some lovely slides that kind of shows, it does reflect the data that we're finding coming out, but this was actually from young people. So the bullet points down here I took from discussions with young people and threads of work that we see most commonly coming in through our ED doors. So this is that cohort of young people. Very often, and maybe some off the back of COVID, a lot of relationship breakdowns and the impact that has on young people. Identity, self-identity, and I think COVID again, when we were not able to go out and be with our friends, we kind of looked very inward. So that's taken had a lot to do with some of these outcomes. Mental health, self-harm, I mean, none of these things are a surprise. And online safety. I had a conversation on the way here, actually. I was talking to a colleague of mine, and so much of the issues that we see young people, there's so much connection back to our phones. And I think as adults, we spend a lot of time on our phones, and we know that it's healthy to put those down. But actually, as a young person, it's not only it's a connection, it's so much more. It's a way of life for young people, and actually that has an impact not only on their safety but on their sleep, on their behaviours, on what they learn. So there's there's lots to be explored there. Next slide. I'd like to introduce you to Dave. So this is Dave. Dave walks into our ED on a regular basis. This is based on a true case. His name was not Dave. No, he doesn't have crisscrosses going across him. But Dave was caught up in quite a lot of peer pressure. He was a really quite a quiet lad, suspected of having autism spectrum disorder, but was on a waiting list. A lot of young people on waiting lists. He was on one of those. He was currently not in employment, education or training. He's 17, so that's not on. Oh, he is up there. And had kind of fallen through that gap. So went to college, kind of didn't engage in college, but there was no one really around him to pick it. There was no safety net really to pick him up and help him find a route back in. And because of that, or maybe not because of that, but definitely allowing him that space to be led off by the people in his neighbourhood, young people in his neighbourhood who were smoking weed and cannabis. Weekends, there was a little community of young people up in the park that would very often be sort of binge drinking over the weekend. And from knowing Dave, I don't think Dave actually really liked that environment, but he didn't know how to get out of that environment because he just couldn't see a way out of it. That was what he knew, and that led to his mental health breaking down a little bit. There was low-level self-harm, but he was really struggling with what was going on in his mind, and he actually came into the hospital because he expressed hearing voices, and that may had something to do with the cannabis smoking. It may have been related to his mental health. My opinion was it was a whole thing. It was all of these things coming together. In the middle of all of that, his parents were breaking down, and he was really struggling with the fact that his behaviour, as he called it, was a cause for that, when actually that wasn't the case in Dave's example, but that's how he felt. But he couldn't express that because he was in the middle of this conflict. And really important is that his interests were gaming and music. Now, when we present these cases to medical professionals, we go on to look at how we would support Dave and how we work with Dave. We're not going to do that in this presentation, but for us as a youth worker, the most important things for me are these bottom things, these two things at the bottom, because they're the way I can connect with Dave. I can help him navigate all of this, but I want to know what's important to Dave before I start trying to work through all of that stuff. So that, to me, I just want to highlight, because that is the most important thing. It shouldn't be at the bottom, it should be right at the top. Next slide, please. So, there should be a big wham. Oh, there it is. It is, wham bam. So, with a flash. Suddenly, right, so we'll move on. So a long-term health condition comes along. So next slide, please. A long-term health condition has a huge impact. This is some stats that kind of evidence that, and these are just examples. I'm sure if you looked on the Association of Young People's Health, I said that right?
Yeah.
You can find more stats, but there's evidence to show, and these were pre-COVID. There's another study called the SHARE study that was led by Southampton, I think Nottingham universities, that shows actually a slight increase. I think it went up to 33%, but it's a slight increase. So an increase of a double chance of having a mental health condition. So it's not good enough just to have the long-term health condition. We're gonna make that slightly more complex for you. And these stats are very similar. So as much as this one is about living with a kidney condition, there are similar findings. So there's more research to show us that this is it's present across all long-term health conditions. So what's going on for a young person living with a long-term health condition in 2023? Well, we can't take away the fact that all of the issues that were going on for Dave, they're probably also going on for young people living with a long-term health condition. So this is not us saying that it's completely different. You've got a long-term health condition and these are going to be what you experience. But these are just some of the examples of the differences that we see young people with long-term health conditions experiencing. So regularly they don't see friends. They're not going to school. they're not choosing to be not in education, employment and training, they're unable to access education in the same way, either because they're spending long periods of time in hospital, or they're simply just not well enough. And they're feeling pretty grotty. Because we know when we wake up and we got a bit of hay fever, it's harder to concentrate that day. But if you're feeling like that every day, even if it's because of the medication that you're taking, and we know that for our kidney patients, for example, some of the medication that they take means that their processing is slowed down. They may have slightly shaky hands, which means that writing is harder. So there's all of these things that are at play for these young people. Hospital appointments. Who here likes a blood test? Anybody like a blood test? Because the young people who have long-term health conditions regularly have to have them every week sometimes. They're not allowed to do things. It's not even that they actually can't, but very often the parents get that. They go to Lidl and they buy, other supermarkets are available. They go and buy cotton wool, and I'm a parent, I do exactly the same. And they wrap the child up in the cotton wool. And that's really hard as a young person, 11, 12, 13, 14, going into adulthood. It's really hard to take that cotton wool off. So when we get to 16, 17, 18, it's no surprise that transition is difficult, because there's all these sudden changes. That's really hard. And these two are really, for me, really stand out. Reduced independence, so that sense of I can't do this, I need help to do this, but increased responsibility, because there is an expectation by healthcare professionals and probably by parents as well, that if you're recommended to take a medicine that will make you feel better, that you take it. You need to remember to take it every 3 hours. You need to set your alarms. You need to remember to drink your 2 litres of water, because that's what the doctors told us to do. You need to not eat the McDonald's that all your friends are eating, because that's what the doctors told you to do. So there's all of these responsibilities that their mates don't have, and actually make them different and feel really different. So it's easy to see that whilst being a young person in 2023 is pretty hard going, let's face facts, there's a lot of challenges for every young person. Being a young person with a long-term health condition is really confusing, and it's a real difficult balance that you can get really easily lost in. Next slide, please. So I'd like to introduce you to Sophie. Sophie is one of my young people that I've worked really closely with. Actually, since I did this case study, has had a transplant, which is really exciting. But at this point, Sophie had stage 5 kidney disease and was coming into hospital 3 days a week for dialysis. She would come into the hospital at about 8 o'clock in the morning, and it was a 2-hour journey one way, so a 4-hour round trip to the hospital for her and her family. She'd come in, she was on the dialysis machine for 4.5 hours, and then she'd go home. So unsurprisingly, did not go to school that day. So that's 3 days, didn't go to school. We're really lucky, and I know a lot of hospitals have hospital schools. We have a really good hospital school at Southampton, and they prioritise, we have a teacher that comes into our dialysis unit and does school. They get 45 minutes while they're in that chair. Now that's a privilege, that's a luxury, but that's 45 minutes on those 3 days. That's not a full school day, and it's not comparable. Sophie, when I started working with Sophie, hadn't been to school at all for 4 months. This was primarily off the back of COVID, huge anxieties around infections and just that social anxiety, really, because as a patient with as a young person with stage 3 kidney disease, they were, I can't even remember the word when COVID hit. They were bubbled. They were bubbled. Shielded. They were shielded. That was the word. They were shielded, not only from the community outside, but from their own families. So young people with kidney conditions had to have their own towels. They had to have their own. They had to eat in their own spaces. I mean, there were some really strict guidelines put in place for this cohort of young people that was incredibly isolating, and Sophie really struggled to come out of that. Hence the high levels of anxiety. Now, for compliance and medication and diet, this was really interesting, because the healthcare professionals that were working with her in this particular case really just didn't get it, and were kind of like, well, we don't understand, because you wouldn't need to be worrying so much about going out if we're taking the medication. By not taking the medication, you're increasing your risk. There was all this confusion, but actually what we identified is this was all Sophie had control over. Sophie didn't have a control over anything else, but she could control what she ate, and actually she liked to eat chips. Potatoes were one of her favourite things. So when the dietitian said you've got to cut out your potassium, potatoes goes, that made her really sad. So we can see why she might not be complying with that. She had really poor body image and self-esteem, and actually that's really common with young people who have long-term health conditions, because for Sophie, she had PD, which is a dialysis through her tummy essentially, so she had scars on her tummy. Then she'd gone to hemodialysis, so she had a line in her chest. So really conscious of those, and Sophie was a really slight girl, so they stuck out of it. And she was interested in TikTok and photography. And again, I don't need to reiterate that, but the way that I worked with Sophie was through that photography. And we did a big project all around body image using cameras. It was really exciting. And actually, the impact that Sophie had on the other 3 young people that she had dialysis with in that room was amazing. And it happens, they have like their own little dialysis community. And it's really lovely when they're all on a similar age, because they can really connect. And unfortunately, we can't arrange that to happen, but it did for Sophie. They were in a room, and it was really, really lovely. And actually, they started using their photography to set up their own TikTok about their journeys, which was really great. Next slide, please. So I hope that we've evidenced that actually these young people have very different life experiences, but the way that we work as a youth worker, whether we're in the community, whether we're in the hospital, whether we're helping them in the school, is exactly the same. We're youth workers following the same values, the same principles, and the same purpose, working with our young person at where our young person is.
So back to our weather in the storm. Just in terms of what's ahead, what's going to happen in the future. Next slide. So there's a number of challenges, and these are where really health-based youth work can help. So the NHS long-term plan is a bit like old news now, but they just released an NHS long-term work plan. One of the biggest challenges the NHS faces is its workforce. It's not about the money, it's about getting people to do the jobs. And actually what youth work does, it presents an opportunity to really skills mix teams. So I think we're just going to see it maybe more and more in health. The next one is a report that was out just last week, which is called The In-Betweeners, which is about the National Confidential Inquiry into Patient Outcomes and Death. Sadly, it talks about young people facing transitions, young people facing transitions between services, face systemic difficulties. It says there's not enough happening for transition between children's health services and adults. And if we think back to when Donna started that youth work back in Nottingham, that was a massive driver. And the NHS talks about 0 to 25, but yet most of our services are still only up to 18. But that's a massive opportunity, actually, because we know it can make a difference. And then the thing that is just sort of on everyone's mind in terms of children and young people, mental health. So I don't need to remind people of the statistics, but 1 in 6 children have a probable mental health disorder. We're facing a mental health pandemic, and actually youth work fits so well with that mental health world and can really add value. So there are storms ahead, but there are absolutely opportunities for health-based youth work, and hopefully it will carry on and it will morph into these other contexts and continue to grow. I think one of the other things is about the research. So what's happening is we've got all these health-based youth work teams. We've kind of profiled a snapshot, but people are going to start saying, well, what difference is it making? How are we evidencing impact? And one of the interesting things is, in the medical world, that is an even more prominent conversation. But what I've learned is that actually a load of these health-based youth workers teams are evaluating impact and they're using really robust outcome measures, but nobody's just gathered it all. So I think you use Warwick, Edinburgh, and so you've got all of these little things. Actually, they are evaluating impact, but nobody's collected it as a whole. So it's not like we need to do more research from the start. It's just we need maybe a call for evidence, and actually somebody needs to get behind this, whether it's the National Youth Agency or UK Youth, and actually put some weight behind it, because actually this is where the money is, and this is where the impact can really happen with young people. Next one. So if you want to get in touch, it's Miss the UK off of my email. So if you're going to email me, make sure you put UK on the end, otherwise it won't get there. You can follow us on Twitter or Facebook, the Health-Based Youth Workers Group. Our tech gremlin from the steering group manages the socials. And we've got an email address, and then that's mine and Sarah's email address. So if you've got any questions after you leave here, you want to know anything, just drop us an email and we'll get back to you. And then we're just gonna, if we've got time for a random thing at the end. Ooh. Oh, actually, no, this one more then. So if you're here, no, you can go back to the next one. A couple of our colleagues are doing some slots tomorrow. So if you want more on health-based youth work, there's Marie Marshall and Nicola Rigby are talking about youth work in Manchester. And this is actually a published article. So this is a proper piece of research, what I call proper research.
And it is a little bit about measuring the impact.
Yes.
So, you know, that making the heavy stuff lighter, it
shows
how you can do that.
And if you Google that, you'll see the actual published article. And then Sean, who is from Safe Now, is talking about hospital-based violence intervention. Again, thinking about that red thread. So that's tomorrow at 1 o'clock. So if you're around, try and have a listen to that. And next slide is our little random thing.
Oh,
So-
right, okay, so I have to go out. To this
You have to go out. What we want you to do is watch this film and tell us where you think the youth worker is. This film is about behavioural change, health behavioural change. But it's like, I like this film, and I showed it to a few other people and they liked it. And we wanted to end on something else. So it's a bit random, but.
Psychologists know that there are two systems in our brains, the rational system and the emotional system. Jonathan Haidt, who's a psychologist at NYU, came up with a great analogy for these two systems. He said, think of your brain as a human rider atop an elephant. The rider represents the rational system. This is the part of us that plans and problem solves. The rider might do some analyzing and decide, hey, I want to go that way. But it's the elephant representing the emotional system that provides the power for the journey. The rider can try to lead the elephant or drag the elephant, but if these two ever disagree, who would you bet on? The elephant has a 6-ton weight advantage, and it's exactly that power imbalance that makes adopting new behaviors very hard. If you want this duo to head a new direction, you also need to think about the path, which represents the external environment. This duo is more likely to complete a journey if you can shorten the distance and remove any obstacles in their way. So bottom line, if you want to lead change, you've got to do 3 things. Give direction to the rider, knowledge of how to get to the destination. You've got to motivate the elephant, which means tapping into emotion. And finally, you need to shape the path to allow for easy progress. That's how change happens.
That's it.
Very good.
So, where's the youth worker in that?
Where is the youth?
Where is the youth worker in that? There's no right or wrong answer.
There is no right or wrong answer.
It's open to interpretation.
The elephant.
You'd say the elephant, any other?
The rider.
Say the rider.
The rider.
What about the part?
What were you going to say?
Well, I was going to say the rider as well, because you're trying to have some objective or rational kind of feedback to someone's emotions. That's certainly my role as a youth worker.
Any other?
I think it's the editor of the film.
Love it.
Systems change as well as
Love it.
understanding the structural context.
We said different things initially. I mean, when I watched that, it was to try and, with CAMS, we were doing some work, and what we wanted to young people to understand was that this principle of behaviour change. And if you look at the start, it talks about the brain, and it talks about left bit, right bit, and then it says the rider is one bit of the brain, the elephant is the other bit of the brain. But actually what really matters is what's on your path. So I would say, but again, it's open to interpretation, that the youth worker is the person that clears the path, and the person that helps the young person that is actually the elephant and the brain, and the elephant and the rider. The young person taps into the elephant to get to their emotion, and then it also helps them navigate. So actually, I would say the youth worker is the person on the path, but it's very subjective.
Convincing argument.
Yeah.
I think I was really inspired by that presentation. I just want to say it was real good news that. And I love that thing about the NHS being a massive employer. I was shocked by that, and I should know better. I'm not sure if I agree though. I think the biggest employer of youth workers now is probably criminal justice.
Oh, interesting. Yeah.
From what I'm seeing, people.
And actually,
through,
the census.
it's absolutely
Yeah.
fantastic.
Yeah.
Picture. I love that.
Yeah. Yeah.
Really inspiring.
I think there's certainly money going in, and
Yes.
there's, yeah, that's the good news. So Don.
Yeah, well, there's crossover, isn't there, in terms of youth violence and the kind of health behaviours approach to youth justice is actually quite closely linked to some of the stuff.
It is.
I guess
And it's great that those services are actually seeing the value of it.
Yeah.
I love that.
Yeah.
And we're finding that too. And I guess from Scotland, and I guess one of the big, I suppose, frustrations is that there's the kind of formal education, the education space in itself is being overspent just in formal education teachers, even though we're talking about education reform, it hasn't come through in terms of the actual budgets. So we're seeing in these other places, which is great. But then actually, I suppose one of the questions I would have around being based in a health context, I'm thinking about some of the research we're doing around Dumfries and Galloway, where it's youth workers bring into the schools instead of counsellors, instead of clinicians. So it's that kind of mixed skill set, if you like, and then researching that. But then they go back into kind of youth work context. And I suppose one of the questions would be, and this applies to youth justice as well, where sometimes youth workers get pulled into, this is probably a great question for now, another space, is how do they keep their professional identity with that other space rather than becoming institutionalised?
Yeah.
And then reproducing, more statutory-based approaches or formalised approaches to that engagement.
Yeah.
And can I just
Yes, you
answer?
go
So
on.
one thing I think is really key for me as a youth worker, because I regularly have conflict, a nice conflict, but medical professionals have an expectation. And so for an example, we take referrals, but if a young person, we explain to the young person what we do, what we offer. If they choose not to engage, then that's their choice. And whereas the health professional that referred them into us is like, well, why aren't you working with them? Well, because they've got our information. They know how to reach us. We check in with them and see if they want to, but we're not enforcing ourselves upon them. So there are little things like that which we come across as just a small example. But the thing that helps me is the network. It's having that network of health-based youth workers that I can go back to and go, okay, so I'm having this issue, and we talk through it because we're all having similar experiences. Helps us navigate those issues and find ways to be certain of our identity, to hold on to our role and not be drawn off into expectations. And we have our own operational procedures within our service, within the hospital. Yes, it has to go through NHS trust governance, but it reflects the work that we do and not the work of a nurse, not the work of a doctor.
And I think they don't want you to be absorbed. So I'm just thinking of the work I've done locally with CAMS, which is a charity. We had this whole debate of, do we just put the money in the CAMS service and employ people through the NHS trust? But we decided that we wanted them to sit in the charity to keep their identity, but actually the clinical people didn't want them to lose their identity. They really valued that. So I think by we've got again standard operational procedures that are youth work based. So I think it's about maybe not being sucked into the NHS and being NHS-fied, stamped all over it, so you lose that. But I think youth workers sometimes are quite strong and resilient and maybe won't allow that to happen. So, sorry.
How does one join your network? Join the network, is it the criteria?
Yeah, I mean, it is a practice-based network, so ideally you do need to be a health-based youth worker, and there's just a link and an MS form, and that's what as simple as what we've set it up. We've got a lot of we're sort of helping coordinate the network, so we're a bit on the peripheral. The magic happens over there. But one of the things the steering group have worked hard to do is to try and keep it a practice, and that might be someone who's managing it when you can be a more senior or just starting out, but it's about that peer-to-peer. What we're finding is there's a whole load of people over here that are looking and thinking, we want to know more. So you've got commissioners, you've got other people, researchers who think, well, how do we be part of the network? Because we're not a practitioner doing youth work in a hospital. We want to know about it because we might want to develop it. So what we said last year was during National Youth Work Week, we would do maybe some webinars where we would showcase what's happening with health-based youth work to the outside world, not just the inside world that are the peer people working in it. And I think that may happen this year. So because there's so many other people that want to know about it. So is that fair to say?
Yeah,
so,
absolutely,
yeah,
absolutely.
yeah. And again, the conference that's happening in October is for people who are practitioners, because it's that peer-to-peer thing which is so important.
You've got to have the password to get in.
Yeah, VIPs.
You're saying sort of the data collection is quite rigorous, although obviously it's not that national picture there yet. Obviously, there's an argument within youth work that data collection be too rigorous, I suppose, too all-consuming, maybe too intrusive to the young people. So how are you keeping that rigorous while, I suppose, maintaining, so trying for it not to be intrusive, I suppose?
I think each organisation will have their own way. So I know sort of in CAMS they use standard routine outcome measures like Warwick, Edinburgh and goal-based outcomes. And there's a whole debate when I was setting up this service about should we be using that, because we have to ask them, the young people and whatever. But I think there's this it's a twofold argument. If we don't evidence it, then when you're working, for example, with a mental health service, they'll be able to evidence their impact. And if you can't, you're going to just sink. And I think you do use some of those validated outcomes.
Yeah, we use the validated outcomes, but as a youth worker, am I still being recorded? I don't think there's much value in them, because the work in Edinburgh, for example, tells me how that young person was feeling at that moment when they ticked those boxes. Could have been influenced by anything that was going on that day. What matters to me are the video montages, the photos, the quotes that they share, their feedback, and like with Sophie, the photography work that she did and the TikTok that she, those are the things that matter to me. They're the things that show the work we do, and I personally think they real some impact, and we look to do all of those things. So I think with the data from the Warwick and Edinburgh Wellbeing Scale and the goals-based outcomes that we use, and obviously also just medical, like the contacts, recording our contacts so we can see the number of hours spent. And we also use levels of intervention. So we try to see, we hope to see a young person go from a level 3, which is a high level of intervention, high, and down to a low. So we see them moving so that they're engaged, they've got high level engagement, but they've got a lower level of need. So it's a little bit objective because it's based on the youth worker they're working with and the young person kind of scoring that together, but it helps them see their journey as well.
And we didn't ask that question in the sign-up form, how are you measuring outcomes, purposely, because and I imagine some are, but others maybe not. And the research that we said tomorrow was a specific piece of research where they deep dive. which are those research are like gold dust, because then it takes the pressure off everyone else doing it on a day-to-day basis, because someone else has come in and done this unique piece of research. And I think there's another piece of research planned that Marie's put in if they get this funding, so kind of watch this space.